Good morning, everyone. It's a pleasure to be here with you. Um, Thank you for that wonderful introduction. My name is Alicia Matthews. I'm trained as a clinical psychologist, and I'm currently on faculty at Columbia University. It's a pleasure to be here at Thomasot as part of their speaker series on global health issues. And it's also a pleasure to meet with each of you. I hope that after the presentation, we'll have an opportunity to talk about strategies for improving the creation of LGBT-related health research here in Thailand or wherever you are. I'm also very interested in learning some of your experiences in this area as well. So our agenda today is I'll do a brief introduction. I'll talk about a concept called scholar activism, which I feel like represents the type of work that I do. I'll then share with you my program of research on LGBT health, specifically as it relates to cancer and cancer risk reduction. We'll share with you, I'll be presenting some of this with Dr. Periot, who will help describe some of his work on recommended measures and theories for use in LGBT health. And then as I hope as a group, we'll be able to share strategies for increasing scholar activism and research here in Thailand, or again, wherever you may be. So as an introduction, I have spent the last 22 years in colleges of nursing, but my actual training is in clinical psychology. I'm very much interested in psychosocial factors that contribute to mental and physical health outcomes. The primary area that I focus on is in cancer prevention and control, specifically, as I mentioned, reducing cancer-related risk factors such as smoking in order to be able to improve health outcomes. A lot of my work is in health disparity populations. And in the United States, that means those communities that are at elevated risk for a range of poor health outcomes due to their social position and economic resources. So that includes LGBT populations, African Americans, those who are HIV positive, and some recent work with immigrant Chinese populations. And then finally, I classify myself and the work that I do as a scholar activist. That term might be new to some of you. So what do I mean when I say scholar activist? Scholar activists are really focusing on using their specific research and research results to address problems in the community or society related to social justice, equity, and issues of civil rights. In the framework of scholar activists, the work is shaped by establishing a series of research questions or testable assumptions about an issue that relates to social justice or health disparities, conducting rigorous research in those areas to answer those questions. So that's the scholar aspect of it. Identifying important research questions, using rigorous research methodologies in order to answer those questions. But here's where the activist part comes in to scholar activism. Those results are not just for us to present at the conference or to send to the journal. No, the specific results of these types of studies are meant to translate into action, and typically in the areas of public policy. So the idea among scholar activists is that our work is not in service of our ego or our own career, but our work is related to helping to improve social justice. Often among scholar activists, the work is very personal because scholar activists typically come from those communities that are most marginalized in our country. This is myself and a close friend were at her brother's wedding, and I was attempting to access through the restroom. And I was stopped by an individual who said that I was in the wrong restroom, and that was providing me with some hassle about trying to use the restroom. As you may know, most public restrooms are sex segregated. That means people whose appearance do not fit sort of stereotypical categories of masculinity and femininity may experience stares, verbal harassment, such as I did when I was trying to access the restroom, and occasionally violence when trying to use public restrooms. This is especially true for our transgender, non-binary, and gender non-conforming individuals. They face many obstacles in accessing public restrooms, which has been found to have both negative mental and physical health consequences. So what would you imagine would be a physical health consequence of being unable to access the restroom? I know some people who often have urinary tract infections, bladder infections from going the course of a whole entire day not using the restrooms because of fear of harassment or violence. So several friends and I, those of us who have had personal experiences of harassment trying to access sex segregated public restrooms, we decided to meet together and to develop a coalition of activists, researchers, civil rights activists, parents who were interested in reform around this area of restroom access. So we developed the Chicago Restroom Access Project. It was a university and a partnership between the university where I was working, another large university, and many activist organizations, some of them listed here. Our specific goal in 2015 was to advocate for public policy change in Chicago, where we would eliminate all sex segregated single stall restrooms. That means any restroom that is meant for one person at a time, one person goes in, closes the door, locks the door. Those should no longer be labeled as men and women, but they should say all gender. That was our objective. So thinking about the scholar activist model, our testable assumption was that all gender single stall restrooms would be acceptable to people and businesses living in Chicago. Our organizing principle was to have as much input for the variety of groups that are impacted by sex segregated restrooms and help them to have a coalition of advocacy efforts. So who are the other populations besides trans and non-binary? We have persons with disabilities. So if I am a male person who is taking care of a female identified person who has disabilities, I'm unable to take that person to the restroom and to help support them. Also, if I'm a parent and I'm a male and I'm a father and I have a daughter, I have to take my daughter to the men's room where there's typically isn't a changing table. So there were many different stakeholder groups who had interest in this issue. The next aspect of it was data collection. We wanted to collect data from a wide variety of community members to get a better understanding on their thoughts, attitudes about changing policy for removing gendered single-stalled restrooms. So our first study was we collected surveys from over 1,000 people who were attending a conference, and we wanted to ask them, give us feedback about what restroom sign choice they preferred. And we got data on that, and we used that design. We also conducted surveys with local businesses. We had and surveyed 91 business owners, and very much supportive of this legislative change. They felt that it would not have any negative consequences for their businesses, and that it actually may improve the satisfaction of their businesses. We also, instead of just looking at attitudes about all gender single stall, there was a theater in Chicago that had an all gender multi-stall. That meant many different stalls, and all people could use them at the same time. We surveyed 64 of their participants, and their comfort level was pretty high. And then finally, we conducted focus groups for women from the violence community, from racial ethnic minority communities, and the transgender community. So all this data were used to help us develop our methods and our strategies. So we used a data-driven approach to inform decision-making about what the restroom sign should look like. We've got valuable input from various stakeholders, as well as data that we could present to decision makers, such as state legislators. And then we were able to raise awareness and advocacy around all gender restrooms. Our work can be found here at the Pride Action Tank. So we developed public education resources as a part of our initiative, so that we could have flyers and other informational pamphlets like the ones that's shown here that helps to raise awareness. We also addressed another civil rights issue related to having to use the restroom that was associated with your sex on your government ID card. We got that removed, and we were advocating for restroom reform on both of our universities, as well as changing the state law. So I'm happy to present that in 2020, our group was responsible for providing all the data, the advocacy, and support to have the state policy change in Illinois. At this point, the Illinois law dictates that all single occupancy restrooms, again, one person, one going in one at a time, has to be designated as all gender. So that's an example of where the issues that impact us on our personal lives, that restrict our freedom, that restrict our civil rights, can be a target for actual activism, scholar activism, that's able to result in significant policy change. So I just wanted to share that with you, because that's a strong identity that I have. And that's a goal of all of my research, is to conduct research that has implications for improving the lives, well-being of underrepresented minority groups. Okay. So I hope that discussion has inspired you a little bit in terms of your own research and your own ability to make change on the local and maybe even the national level as it relates to LGBT civil rights. Many of us think that we have to be major researchers or major politicians to bring about change. That isn't true. The first meeting of our Chicago Restroom Access Project happened at my kitchen table, in the spirit of the old school activism, and that people who were dedicated to change came together and brought about change. So next, I'd like to transition to talking about my program of research, smoking and smoking cessation in LGBT populations. But I want to talk about it in the context of how you might think about either starting work on LGBT populations or thinking about or thinking about how to answer important questions, additional questions about the topic that you may be interested in. So when I think about it, developing a program of research, the first thing that is required is to identify a key problem that is either experienced at a higher rate in LGBT populations, associated with worse outcomes in LGBT populations, or it's a problem that is unique to LGBT population, right? So problem identification, thinking about what physical, mental health, or social issue that you're addressing is the first step. Thinking about what problem am I focused on and why is that problem important? When I think about my own research related to cancer prevention, we know that smoking is the leading cause of preventable disease and death worldwide. And it is the leading cause for several cancers, not in the United States, not just lung cancer, which many people are familiar with, but it's associated with breast, colorectal, uterine, cervical cancer, and also associated with cardiovascular disease. So each year, nearly 500,000 Americans die from either directly smoking or exposure to secondhand smoke. The current rates of smoking have improved substantially. In 1965, the Surgeon General in the United States, for the first time, definitively said that smoking is harmful to your health and is the primary cause of lung cancer. Prior to that, the public felt that smoking was not harmful, and in some people thought smoking was actually beneficial. In 1965, when the Surgeon General declared smoking as a significant health risk, a number of policies were put into place, such as Clean Air Acts, not being able to advertise cigarettes in magazines or on television, and a number of other policies related to trying to reduce access to harmful cigarettes. As you can see, the rates of smoking for both adults and students have declined significantly due to these public health initiatives and public policy. Currently, rates of smoking among adults are at around 10%, which is significantly lower than the over 40% when public policy was first put in place. Despite these progress, we see tremendous disparities or differences in smoking rates based on sexual orientation and gender identity. The heterosexual population, when these data were collected in 2016, was smoking at about 15%. That's a little bit lower now at 12%. But look at the higher rates of smoking among transgender adults and lesbian, gay, and bisexual adults. Transgender adults smoking at double the rates of cisgendered counterparts. We see the same problem among adolescents. This was survey data collected from high school students in grades 9 to 12. And what we saw that LGBT students, lesbian, gay, and bisexual students was smoking at much higher rates than heterosexual or even unsure students. So we see that this, given the high rates of smoking in the adult population that we expect in the future, high rates of smoking-related health disorders, as well as given the high rates of smoking among our adolescents, we expect that this high trend and high levels of smoking will continue for some time into the future. So that indicates to us that we have a important problem area, a health risk behavior that needs to be additional research and attention focused on. In addition to the direct effects of smoking, we know that smoking exposure to secondhand smoke is a significant health risk. More than nearly 35,000 Americans each year die as who are non-smokers, but who are exposed to secondhand smoke. And what we find is that among sexual minority women, transgendered women, as well as lesbian and bisexual women, we're seeing much higher rates of exposure to secondhand smoke. So tobacco is an important issue for the LGBTQ communities in terms of health consequences. So in the United States, the estimates that there are more than 9 million LGBT adults who are in the United States. And given these high rates of smoking, we have the high possibility of adverse health consequences currently as well as in the future. The second question that we ask is, why are the risks for smoking higher in LGBT population? So first we ask, is there a problem that's higher in the LGBT populations, or there are worse outcomes? Once we have identified that question, then our research needs to lead us to understanding why is this risk higher in our LGBT groups. There are a number of factors that are associated with elevated risk. Blaznik in 2012 put together an important paper that helped us to identify 3 categories of risk that help to explain elevated risk among vulnerable populations. First, he identified demographic characteristics that are universal, that are pretty much consistent across all population groups, regardless of their social status. So general universal demographic factors such as education or income. The second category is psychosocial risk factors. Now, these psychosocial risk factors are shown to be associated with the health risk behavior or the health outcome, such as smoking, but they are more common in our LGBT population. And then the third category are those unique risk factors, those risk factors that are not experienced by the general population, but occur in terms of LGBT population, so unique risk factors. So let's first look at demographic risk factors that are pretty much universal when it comes to health risk behaviors. We know that we see higher rates of smoking, drinking, and drug use among young adults. And that's pretty consistent across all population groups. And it's also true for smoking. We see differences based on race, ethnicity, education. Education is a very strong predictor of health risk behaviors. The more education you have, the lower likelihood of smoking. The lower your education, the higher likelihood of smoking. And that's true for the general population. Men are much more likely than women to engage in health risk behaviors such as smoking. And in our country, in the United States, we see differences in the geographical region where people live in the country. We also see differences in smoking rates. So that's for the country in general. Well, what do we know in terms of LGBT population? I've been involved in a number of studies that have looked at demographic factors and how it relates to smoking among LGBT groups. And similar to the general population, we see differences in age, with younger LGBT adults being more likely to smoke than olders. Then we see differences based on race, ethnicity, gender, and gender identity, with women, sexual minority women, and trans populations being much more likely to smoke. And then lower education groups have higher rates of smoking. So the first question that we looked at were Similar to the general population, are there demographic risk factors associated with smoking in the LGBT population? And we identified, yes, they are. And here's another example when we look at differences, specific example when we look at smoking differences by gender and gender identity. Among men, we see the highest rates of smoking among gay men and trans men, transgender men who are transgendered, and among bisexual women and transgender women. Here you would call them ladyboy or katui, and transgender men would be typically Tom in the Thai context. All right, so we see differences based on gender and gender identity related to smoking. The second category that Blasnik identified was higher levels of psychosocial risk factors. In the general population, we know that depression and anxiety, substance use, and victimization, violence, is associated with higher rates of substance use, including smoking. We also know that sexual and gender minorities have higher levels of these psychosocial risk factors. We know that rates of depression and anxiety are higher in LGBT populations, and alcohol abuse and victimization. So these psychosocial risk factors are not different than what we see in the general population. They're much more prevalent in LGBT populations, which increases the risk for smoking. And we found that was also true in a number of studies that we conducted. Higher rates of depression and anxiety were associated with higher rates of smoking in LGBT. If you were a binge drinker or had higher rates of alcohol, you were more likely to smoke as in the LGBT population. And if you reported childhood violence, experiencing childhood or adult victimization, either physical or sexual abuse, you were also more likely to be a current smoker. So those were related to some of the higher concentrations of psychosocial risk factors. Now, the third category that helps inform higher rates of health risk within minority population are unique risk factors. These risk factors can come from a variety of different variables. A lot of it has to do, though, with the discrimination that is experienced by that group in the larger population. These unique risk factors are most commonly identified using qualitative methods because they requires a lot of in-depth conversation and discussion by individuals who are impacted, who are in the LGBT communities and who are impacted by these issues. And it requires a lot of research across the variety of potential risk factors. So what are some of the risk factors that are unique to LGBT populations as it relates to engagement in substance use, including smoking? Our work in this area has been informed by the minority stress model. The minority stress model says that there isn't anything that's wrong with LGBT populations that contributes to worse mental and physical health outcomes. It relates to the levels of discrimination and stress that we experience over and beyond what is experienced by the general population. So Elon Myers developed a minority stress model that helped us to understand that racial and ethnic minorities, as well as LGBT populations, have worse mental and physical outcomes due to a combination of general stressors that are experienced by the general population and unique minority stressors that are not experienced by the general population, but are experienced by the LGBT population. That was the first part of his theory. The second part of his theory helped to identify what were some of the unique types of stressors that were contributing to higher rates of mental health disorders, higher rates of physical health problems, and higher rates of substance use disorders. He identified discrimination as one of those risk factors. He identified internalized homophobia related to one's sexual orientation and internalized transphobia related to one's gender identity as being an additional stressor. Internalized homophobia and transphobia means that just like we hear negative attitudes from the general population about LGBTQ individuals, like many people in the general population, some members of the LGBT communities, because of religious training, because of societal influences, and because of messages that they receive from their family members, they are also likely to internalize or to have some level of belief that these negative attitudes are true, and that they would be, as a result of that, they would like to change. They do not want to be LGBT or trans. The third category that he identified was concealment, level of outness. We find that in some circumstances, level of outness is associated with better mental health because of social support and being a part of a supportive community, and that there is really strong levels of sexual risk behavior, anxiety, depression, and substance use disorders among individuals who are not out, who are concealing their sexual orientation or their gender identity. So these are some of the unique minority risk factors that was identified in the minority stress model. So let's look at some of these categories. First was discrimination. A number of studies link reports of discrimination based on sexual orientation and gender identity associated with higher rates of tobacco use. Here's a citation for a study that I was involved in. It was using a large national data set in the United States, and we found, yes, higher rates of discrimination, reports of social discrimination due to LGBT status was associated with higher rates of smoking. We conducted another study that looked at whether or not the number of minorities or stigmatized social identities were cumulative, meaning that what was their worst risk outcomes if you belong to multiple groups that are stigmatized or experience discrimination compared to just one. So in our study, we defined stigmatized identities as being lesbian, a member of a racial ethnic group, and having low educational attainment. So you can see here, we looked at current use, current smoking, and lifetime smoking here in the blue. If you did not have any of these, belong to any of these social groups, you were heterosexual, white, and had high levels of education, your current smoking rates were about 10%, and your lifetime rates were about 55%. If you fell into one of those risk categories, either you were lesbian, a racial ethnic minority, or low education, your risk for current smoking was much higher. If you fell into two of those categories, we see higher rates of both current smoking and ever smoking, lifetime smoking, But look to see what happens if you fall into all three of those social categories. The current rates of smoking, if you were a lesbian, who were African American or Latino or Asian, and had low education. So three stigmatized social identities. Your rates of smoking, current smoking, were about 50%, and your lifetime rates of smoking were close to 80%. So these data should suggest that there's something cumulative or compounding about falling into multiple minority groups. Okay. The second area that's a unique risk factor for sexual and gender minorities is experiencing of higher rates of physical violence, and in some cases, sexual violence. As I showed you in one of the earlier slides, we had much higher rates of smoking among sexual minority youth and adolescents, school-age children. My former postdoc, and some of my colleagues and I conducted a study using secondary data analysis that looked at all students in a representative sample of students in the Chicago area. We collected, the survey collected information about sexual orientation and whether or not they experienced school-based violence and current smoking. Current smoking among sexual minority youth, meaning gay, lesbian, bisexual, or unsure, were 2 to 4 times higher than heterosexual groups. So significantly higher than heterosexual students. And we were interested in what predicts this higher rate of smoking. So what is the key risk factor that's related to both sexual minority status as well as smoking? And we looked at the literature shows that there's much higher rates of violence experienced by youth. And we found that there was a direct relationship between sexual minority status and current smoking, but a portion of that was explained by higher rates of school-based violence. So if you are LGBT youth, a lot of the risk for smoking was captured in your being much more likely to experience school-based violence. So that is a unique risk factor for smoking that it occurs among heterosexual population, but at a much higher rate among LGBT youth. Another risk factor that is unique to LGBT population is rates of family rejection. We know that many LGBT youth are homeless in the United States and in other parts of the world because not that they've run away from home, is that they've been kicked out of their home, forced to leave by their family based on their sexual orientation or their gender identity. So there was a study that looked at the relationship between family rejection and health risk behaviors in adolescents. This study specifically looked at smokers, and we found that if you experience any of these types of family rejections, either you were taunted or mocked for being a sexual minority or gender minority, they said negative comments up to you about belonging to LGBT, they said bad things around you about other LGBT, and that they made you feel bad because of being in this community or being either gender non-conforming. These items were strongly associated with higher rates of smoking, about 15% higher rates of smoking among adolescents who did not experience family rejection. This same finding is very powerful in the adolescent literature. So if you are studying adolescents and you're interested in health promotion and trying to prevent adverse health events in this population, looking at issues of family attitudes, family rejection is key because we see family rejection associated with higher rates of homelessness, higher rates of mental illness, higher rates of HIV and other sexually transmitted diseases, higher rates of drug, alcohol, and smoking, and of course, mental health issues. So if you're focusing on adolescents, this is a key risk factor. If you're focusing on adult population, we know that our experiences that we have growing up in our family are very strongly shape our own experiences and how we feel about ourselves. So family rejection is very likely a key risk factor to internalize homophobia or internalize transphobia. So even if you're working on adult population, understanding their childhood experiences with a focus on family rejection, as well as another category called adverse childhood experiences, ACEs, adverse childhood experiences, ACE, adverse childhood experiences are very, very strongly associated with a range of mental health disorders and health risk behaviors in the general population. It's a new area of research, emerging area of research in LGBT populations. And the research so far shows that LGBT population have higher rates of adverse childhood experiences, including violence, family rejection, and it's very strongly correlated with HIV, substance use, and mental health disorders. So if you are looking for an area of research, understanding adverse childhood experiences, characterizing it here in the local Thai context or where you're at is an important and emerging area of research. The next area relates to community norms and attitudes. LGBT populations, just like other populations, have formed a community of people who are similar. And whenever people gather who share similar attitudes, beliefs, social identities, they start to establish cultural norms and behaviors that start to get identified and be accepted as common or normal within that community. So we've been able to identify a number of cultural norms and attitudes in the LGBT community that increases risk for smoking. One is that many LGBT do not think that smoking is a very big problem in the community. Why? Because they point to issues of violence. They point to issues of HIV. They point to issues of meth and other very serious drug use that have a big impact on the community. As a result, they see smoking as, it's not that big a deal compared to the other health risks that we're facing. But indeed, smoking is a significant problem in our communities, especially when it relates to individuals who smoke. Lowers the effectiveness of antiretroviral medications. So HIV positive individuals who smoke have typically worse HIV outcomes, including lower lower control of the amount of HIV that's in the system. Smoking is also significant for trans women who are taking estrogen. Smoking with estrogen places them at higher rates of cardiovascular risk, such as similar as women, biological women who have estrogen. The second is related to permissive social norms. We experience so much discrimination, so much rejection outside of our communities that we are very tolerant of the behaviors of people within our communities. We have a mindset of, I don't want to be judged, so I'm not going to judge you. So live and let live kind of attitude. So that relates to a lot of social norms that are accepting of smoking. Whereas in the heterosexual community, the social norms are against smoking. And so that is a tendency to reduce acceptability of smoking, and people want to quit because of that. And also in the communities, we see smoking is or related to several of our identities. So we think smoking makes us look more sexy or makes us look more masculine, if that's what we're trying to portray. So we see that social perceived threat, social norms, and the relationship between smoking and different identities is very prevalent in the LGBT communities. So these are community norms and attitudes that also need to be understood and changed if we're going to be able to improve health on across our communities. Another issue relates to the importance of bar cultures. In the 30s, 40s, 50s, 60s, 80s, and into the 90s, the bars were about the only place that LGBT populations can safely gather together for enjoyment, for dating, for socialization. But what happened that we found that the more time that you spend in bars, it increases the likelihood that both you drink and drink at very high levels, and that you also smoke. And so we found that the more that a person was engaged in the bar culture, the nightlife, the going out and drinking, the higher their likelihood was of smoking. So we see that the places where we go, and especially the bars, were associated with higher rates of smoking. We are also, in the United States, targeted by the tobacco industry as well as the alcohol industry. That means before it became more socially acceptable to represent LGBT images and themes, the tobacco and alcohol communities were engaging with the LGBT communities. And as a result of that, we thought they were our friends. We thought, yes, we need to support the tobacco industry. We need to support the alcohol industry because they're supporting us. But really, they were just looking for a new community to sell, get addicted to alcohol and to tobacco, a new community to sell to. So we saw targeted advertisements in the LGBT newspapers, magazines, and billboards in the communities where high numbers of LGBT live. We also saw language, which was clearly targeted to the LGBT community. I choose, march, meaning protest, pride, meaning terminology that we associate with the LGBT communities. So these are the ways in which the tobacco industry became very much a part of the LGBT community, supported pride events, supported LGBT organizations, and as a result of that, there was no strong protest or anti-smoking campaigns. So that has been a risk factor as well. Beyond what we see as risk factors that relate to community issues and the social environment, we also see unique risk factors as it relates to research and treatment. There are very, very strong evidence associated with the benefits of smoking cessation interventions. But my colleague and I, Dr. Lee, we did a study that evaluated the literature on tobacco interventions in LGBT communities. What we found that the research was extremely limited when it related to smoking cessation strategies for LGBT smokers. Why is that important? Because we saw that there was a large number of psychosocial and unique risk factors that were associated with smoking in our population. As a result, treatments need to be maximally effective. Treatments need to include several of these psychosocial risk factors, such as depression and anxiety, as well as some unique risk factors, such as exposure to violence, as well as having a social network where smoking is likely to be much more common. If our friends are smokers, it is much harder for us to quit. So these are some of the things that will need to be taken into consideration when we're establishing treatment programs for LGBT smokers. But in 2014, we saw very little of that. In the past, 10 years ago, there was very little of that research in the literature. So those are some of the risk factors that increase rates of smoking. So just to review, we were looking at demographic risk factors. We saw those. Then we looked at other types of risk factors related to demographics, psychosocial, and unique risk factors. The next area that we look at when we're thinking about our program of research is how to intervene on or how to reduce the problem that we are experiencing, that our communities are experiencing, and that we want to try to improve. So the first step in developing your program of research is identifying a problem. The second is identifying what are the risk factors, demographic, psychosocial, and unique risk factors. And then the next category is how do we develop interventions that help us to eliminate or reduce the problem? Well, smoking cessation research is very much limited by a number of factors. The lack of diversity in clinical trials, and a lack of specific outreach, and trying to increase high numbers of LGBT individuals in smoking cessation research. Very few studies include measures of sexual orientation or gender identity so that we could start to see whether or not there were differences in treatment outcomes based on sexual orientation or gender identity. So we also found that there's very limited research on interventions that address some of the unique psychosocial and community risk factors. And we have very little evidence in terms of how are the best ways to recruit LGBT populations into research studies, and what are the best way of retaining them. So each of you in your area of research, you have the ability to start to show leadership in terms of including measures of sexual orientation and gender identity on all health and mental health studies, regardless of what the topic is, because LGBT research is more than just HIV and mental health. LGBT research includes diabetes. It includes family planning, contraception use, unintended pregnancies. It includes reaction to COVID. It includes a number of different things. So anything that is a health issue for the general population is also potentially a health issue for LGBT populations. So we need to be thinking a lot out of the box when we think about what's appropriate research. Diabetes, because we are in the United States, sexual minority women in particular are much more likely to be overweight and obese, which increases risk for diabetes, hypertension, and cardiovascular disease. So thinking about any studies that are looking at physical activity, obesity, or diabetes would be appropriate for including standardized measures of sexual orientation and gender identities. That would allow you to work with your colleagues to do some secondary data analyses to look and see, are there differences between sexual and gender minorities and heterosexual and cisgender individuals on obesity, hypertension, or cardiovascular disease. In addition, it's really important for us to collect the qualitative and survey data that help us to understand what are the unique risk factors so that we can begin to understand how do we culturally target our interventions for LGBT populations. And then in addition, we want to be collecting very careful information across all of our studies that helps us to understand what are the best practices for recruitment. In person, if it's in person, where are the best locations? If we identify the locations, how is it that we develop the targeted advertisements or flyers to advertise our study that are acceptable and attractive to the LGBT communities? Are there key stakeholders that allow us to identify populations that might be a little bit harder to reach? So just like there's a lot of diversity within the heterosexual and general population, there's also a lot of diversity within LGBT populations. So strategies that would be used to recruit men might be very different than recruiting sexual minority women. Strategies that would be used to recruit adolescents are likely very different from the ones that we use to recruit older adults. So as we think about recruitment strategies and community engagement, it also includes working with people who are members of those communities, youth, sexual minority women, older adults, who can help to advise us on best practices. Who do we need to talk to meet these recruit older adults? Usually, if you have community advisory groups who include members of the target population that you're trying to reach, HIV positive or sexual minority women or lesbian adolescents, it's good to form an advisory group of people who either run social organizations for that target population, people who have research or clinical expertise on that target population, and people who belong to that target population. So identifying 3 to 8 individuals who work clinically or with organizations, who work research and who belong to those populations to form what we call a community advisory board. These community advisory boards are very, very, very vital for not only helping us to recruit, but helping us to understand what are some of these potential unique risk factors. And they also can help us to build trust among these communities, because in many LGBT communities, it's still very stigmatized. So people might be a little bit concerned about participating in research. And so having trusted members of the community in our community advisory group can help to overcome some of those barriers. So thinking about increasing studies that are specific to LGBT communities, thinking about including sexual orientation and gender identity on surveys, all surveys, regardless of the focus, understanding unique risk factors and development of qualitative studies that help us to identify unique risk factors, that help us to target interventions. And then finally, to have community advisory board that helps us to understand how to engage, recruit, and retain. Okay? All of those help us to build our evidence base, not in just one category of LGBT group research, like I'm focusing on smoking. I don't want all other LGBT smoker research to only focus on smoking. I want to build capacity across a number of clinicians and researchers who are addressing a range of health risk and outcomes so that we can build capacity across a number of domains so we can show leadership in the professional organizations related to psychology and adolescence and nursing and social work as it relates to a number of topics. So our goals are to help think about building capacity, knowledge, collaborations, and skills so that we might be able to help build the infrastructure and capacity across Thailand and neighboring countries to do this type of research. Remember, from a scholar activist standpoint, knowledge is power. Knowledge allows you to advocate to shine light on problems, to identify specific mechanisms that can help to reduce the problems, and to be able to advocate for change. Okay? So when we're thinking about intervening on or developing interventions, we think of three primary strategies. The first is creating resources that help to educate the public and the practitioners, whether they're mental health practitioners or physical health practitioners, nurses, social workers, physicians, providing resource and community organizations, providing resources that help to raise awareness about the problem and to provide some recommended strategies for how to support members of the community or how to better inform nurses and other care providers on how to improve outcomes. The second relates to the second category of solutions or interventions is to create evidence-based treatments. Again, those are related to randomized clinical trials or implementation science studies that help us to understand what are the best practices for reducing smoking among LGBT population. And then finally, the category for solving problems, a focal point for interventions is policy change, public health policy change. At the beginning of the presentation, I gave you an example of policy change as it relates to access to public accommodations in the area of restrooms. But there are also all other types of policy changes that would have implications for the LGBT communities, such as civil rights, ability to marry, ability to transition and have your birth certificate changed, have your government ID changed, public policies that reduce discrimination in education, housing, employment, and healthcare. That would be some of the types of policy changes that would be appropriate. So let's talk about a few of those. Development of LGBT specific resources. I've been involved in several of these initiatives in which we have put together information about addressing tobacco in LGBT communities, helping educate practitioners about evidence-based strategies for smoking cessation, thinking about establishing a program of research to help us better identify how to address, to prevent, and to reduce culturally targeted group interventions. So many of you think, well, I'm not a big researcher, I'm a clinician, I work in clinical practice. You can have a very important role in this area, that is putting together high quality educational resources for patients, for educators, as well as for other clinicians on how to improve healthcare for this population. So clinicians are excellent for building our evidence base as it relates to resources. Okay. Also, clinicians are very important to pair with uh, uh, researchers because of having access to populations of interest. So if I'm a researcher, it helps very much for me to partner with a clinician who might be working with adolescents, LGBT adolescents who have depression. That allows me to have access to the target population, to be able to test some of my intervention components, and then to work collaboratively in terms of identifying a final intervention approach. So wherever you are, whether or not you're in an organization, you have the ability to help with development of interventions, whether you're a researcher, a policymaker, or a clinician. Multidisciplinary approaches are very, very important. So developing resources. The second is working with community-based organizations in order to develop culturally targeted interventions that would be used in their patient population. So I worked very closely with Howard Brown Health Center in Chicago in the United States. Howard Brown Health Center is the largest LGBTQ mental and physical health center in the Midwest. So for Chicago and for the surrounding region, this is the largest community health organization. They have a lot of programs in place to support LGBT communities, therapy, family planning, as well as physical health. And I met with the leadership at Howard Brown, and I showed them the data around smoking. They were also very aware of high rates of smoking in their patient population. So we worked together collaboratively to write a grant together and to be able to develop and test a culturally targeted smoking cessation intervention that would be delivered at Howard Brown Health, a trusted location, a trusted organization, and an organization that had the infrastructure in place to help recruit and deliver this intervention. As part of it, we developed community advisory boards that helped us to develop the title of the program, to develop images that help us to recruit women, to recruit younger women, to recruit men and sexual minority women. So we had developed together a lot of advertisements that were targeted to a specific community that helped us to increase our outreach and engagement. So what was the study that we conducted together? It was called Bitch to Quit. This name came directly from the community when we were doing some qualitative work to understand what they thought about quitting and what they thought would be a good name for our intervention. And one of the participants said, "Yeah, it's a bitch to quit." And someone said, "That's it. That's the title. It's funny. It's along with LGBT type humor, and many people in the group like this name. We usually refer to it as BTQ, but the full name is Bitch to Quit. It was a randomized clinical control trial that was funded by the National Institutes of Health. It was a 5-year study that included 345 participants. was a collaboration between my institution at the time, University of Illinois, Chicago, and Howard Brown. The intervention was to compare the benefits of a standard smoking cessation treatment, cognitive behavioral therapy, with standard intervention approach for smoking cessation. The BTQ intervention was these standard elements, plus it was targeted to include information about smoking data for LGBT communities. It provided information about community norms, community-specific barriers and triggers, and used a lot of specific imagery and language and quotes from community members. So it included the same curriculum, but it was targeted to the LGBT community. It was 6 weeks of group therapy, and included medication, either nicotine patch or the gum. We know that the best evidence suggests that a combination of treatment, cognitive behavioral treatment, over time paired with nicotine replacement is the best evidence for smoking cessation. So our research question was, first of all, are cognitive behavioral therapies effective for reducing smoking in LGBT communities? Because remember, at the time of this study, this was the first funded, this was the first National Institutes of Health funded randomized clinical trial to study smoking cessation intervention among LGBT in the United States. So we were trying to answer a couple of important questions. The first was, how do LGBT participants do in a standard smoking cessation treatment? Because before we need to say that LGBT groups always have to have a culturally targeted intervention, we need to answer the first question of how do they do with the standard treatment? This poor results on the standard treatments inform us that we are likely missing some unique risk factors for this population, and that additional work needed to be conducted to conduct a tailored intervention for the group. So then the second question was the tailored program associated with better smoking cessation outcomes and better acceptability and satisfaction? We found that regardless of the targeted or culturally targeted intervention, is that the quit rates were very acceptable. So the quit rates were in line with what we see in the general population among smokers in general at 1 month, 3, 6, and at 12 months. We got good rates of objectively verified smoking cessation rates. The other thing that we found was the groups did not differ, the standard versus targeted, on terms of quit outcomes, retention, or treatment completion. But what it did differ on was that the study participants were much more satisfied with the BTQ intervention. They thought it was directly correlated, connected to them and their needs. They found the materials acceptable and positive, more positive than the standard intervention. So our takeaway message from this research is that cognitive behavioral strategies have benefit for LGBT communities. We can increase the level of satisfaction and acceptability by adding cultural targeting and delivering the intervention in a culturally safe space, such as the LGBT health organization. So minimal requirement is evidence-based evidence-based cognitive behavioral intervention that is safe, supportive, and people feel welcome. To improve acceptability, add LGBT location, and culturally targeted materials. Okay. So here is a summary of the smoking cessation, my program of smoking cessation research. I've been able to identify that rates of smoking are higher in the LGBT communities. We've been able to conduct studies that have identified what are some of the demographic, psychosocial, and unique risk factors to be able to educate the rest of the scientific community. We have used the minority stress model as an organizing model for helping us to identify risk factors, and that we also know that the social ecological framework is important for us to think about interventions that are directed towards the individual, such as addressing internalized transphobia, increasing outness, interventions that are at the relationship or interpersonal level, such as dealing with family rejection, increasing support, right? This is work that can be done with non-LGBT communities and with LGBT communities. There's evidence that suggests that there are norms and attitudes in the LGBT communities that need to be the target of intervention, as well as societal factors, such as policies, including reducing discrimination, as well as related to LGBT identities, as well as policy related to tobacco control. So minority framework can help us to identify some of these risk factors, and the social ecological framework can tell us that their interventions need to take place at the individual, interpersonal, community, and societal levels. Finally, we have evidence that culturally tailored interventions are effective and well received in our target population. So this is an example of one specific program of research related to LGBT health. But what I've tried to do is to illustrate how you can build your own program of research in your topic area and some of the factors that you want to consider. Now we're going to shift gears a little bit and have Dr. Perio talk to you a bit about building research capacity in Thailand and some of the work that he's done that might be useful for you in Thailand or in other parts of the world. So at this point, I'm going to hand it over to Dr. Perio.
Thank you so much. Thank you for the wonderful presentation at the first part of this special lecture. So I am Parayot Kittitirsak and Assistant Dean for International Research and Communication Affairs at the Faculty of Nursing, Thammasat University. So my background is I am a mental health and psychiatric nurse and also work on the LGBT research. As your listen from Dr. Matthews, Dr. Matthews gives a lot of idea on how to conduct the LGBT research in the context of the US or in terms of international perspective. I also have opportunity to learn a lot from Professor Dr. Matthews and also think about how to create the research in LGBT in Thailand. Because if I look back around 5 years ago, is a limit number of LGBT research that conducting in Thailand, my countries. But I think as Dr. Matthews said, LGBT populations has at a risk group, higher risk group for facing with the health disparity. So that's why I'm looking at the context that we have in terms of research and how we can create those research in my own country. I started with looking for the gap. Among about last 5 years ago, we have a small number of the research in LGBT and also those research that conduct in Thailand using a small sample size and also collecting data in the some specific area of Thailand, for example, in the central of Thailand or in Bangkok. One major point that we found that when we try to check the fundamental of knowledge of research in Thailand, we found that they do not have a standardized measure and also do not apply the well-known or standard of the conceptual framework. Since I found this, I worked with Dr. Matthew closely to step over this obstacle. And so that's why we try to start with framework, frame our study using the standardized of the conceptual framework. We apply the minority stress model to guide our research at the beginning of the stage. So the minority stress framework is very well known and comprehensive framework that capture all of the factors that we think is contribute to the health outcome. So you can look at for the detail on the publication of the minority stress model. And once we try to capture those factors that we think is a contributing factor for the health outcome, we see that another obstacle is we lack of the standardized measure. So I have to start up with translate all measurement using the standardized measure from the US and translate it into Thai language using a strategy like a committee approach and also using forward and backward translation to make sure that all things, language differences can consistency to each other and also respond to cultural sensitivity in terms of applying to Thai context. So we start with translation of the SOGI measure, sexual orientation and gender identity, because in Thailand, we have some limitation of understanding the term of use and how we classify LGBT people from other general population or heterosexual or cisgender. So we conduct a pilot test to verify the measurement of SOGI that we translate into Thai to make sure that Thai people understand the term well, and that term that we use, that we translate from English, is matched with a perspective of Thai people. And we found that this measurement is high, it has a quality in terms of comprehensive and understanding once we try to test it among Thai populations. So that is the first step that we did, because if you want to start the research, we have to have a standardized measure, right? And then we still found that in terms of minority stress, another factor that related to the conceptual framework still lack of the standardized measure. So that's why we start another translation to translate those standardized measures. For example, experience of discriminations, victimization, illness inventory, and internalized sexual stigma, to make sure that we have all measurements that link to the conceptual framework that we want to use in our study. So once we translate it all, we conduct a research using cross-sectional study during 2020, and then we apply all measurements that we translated already into this study. We collect the data among the Thai LGBT participants aged over 18 using the convenient and snowball sampling, and collecting data access using a recruitment strategy online and in-person survey in collaboration with Rainbow Sky Association of Thailand, which is the first well-known organization that devoted to LGBT rights and health. The reason why we have to collaborate with outside organization, because we think collecting data among LGBT population is quite challenging due to the level of awareness, right? So Thai participants may not accept LGBT well, so we have to find someone or some organization to be a voice for us in terms of distribute the survey. So that's why once we collaborate with the Rainbow Sky Association of Thailand, we got a quite high number of participants in our study, like around 411 people. Okay, and we use the descriptive analysis to analyze based on our study objectives. We found that most of our participants graduated in bachelor degree have income in like a middle to low income and have uninsured health insurance. In terms of SOGI, we found that the majority of our participants were male, 90% identified themselves as homosexual, around 80%, and also being cisgender around 76%. In terms of chronic disease, we collecting data on they have some kind of chronic disease that they have to follow up with the doctor or taking a medication. Around 70% say that they don't have one, but the rest say that they have one type of chronic disease, and most of that is peptic ulcer. So in terms of health risk factor, we asking them about smoking status, alcohol use, and drug use. So most of them never smoke and drink alcohol rarely, like once a month, and never use drug in their life. So in terms of minority stress, if you understand the minority stress, they say that is a specific stressor that contribute to those LGBT population besides general stress. So in terms of minority stress, it's combined with this experience of discrimination, victimization, concealment, and internalized homophobia. And once we got the result, we found that most of our LGBT participants have faced with the victimization one time in their lives, almost 70%, and also faced with the discrimination from social setting, either like from families, from school, from workplace, around almost 60%, and also have a little bit high level of LGBT identity that they disclose themselves to others, and have a little bit in the middle range of like an internalized homophobia level. In terms of stress, I think the majority of them have a moderate to very severe level of stress, and also the same in line with loneliness. Around 40% of them have moderate to severe level of loneliness as well. So in terms of the health outcome, I'm looking the minority stress and also the impact of the minority stress on the health outcome, which is I can say that we try to look at the severe mental health outcomes such as like a depression and also suicidal behavior and suicidal ideation. So for depression, we found that around 40% of LGBT participants have mild to severe level of depression, and around 40% have lifetime suicidal ideation, around 20% have 12-month suicidal ideation, and 13% among them have suicide attempt. Once we look at the contributing factor to those mental health disparity, we found that the cause of the suicidality is different, depend on the outcome, what we measure. For depression, we found that the predictor is linked to younger age, having chronic disease, and also those health risk factor. Social discrimination is one of minority stress that contribute to depression. For suicidal ideation, lifetime, social discrimination still be the same. That contribute is that we consider as a contributing factor for suicidal ideation, plus with those chronic disease and level of stress and loneliness. So for 12-month suicidal ideation, we found that some of the health risk factor, for example, smoking status, is a risk factor for suicidal ideation. And for minority stress, you can see that victimization become a contributing factor of the recent suicidal ideation. For suicide attempt, we found that those factors that contribute the LGBT participant to attempt of killing themselves is internalized homophobia, or the feeling that they fear or hate themselves, right? To born or to be or to have an LGBT identity. For the rest, is linked to health risk factor and also social demographic factors such as living in poverty area, have poor health status, and also using alcohol and having chronic disease. So we can claim that this is a summary of my study. We can claim that all of indicators of suicidality were influenced by minority stress, which is linked to the conceptual framework that we choose. Maybe it's not perfectly fit with the model because the factor that contribute to those health outcome is very depend on type of the health outcome, but we still can see that those factor is strong enough to contribute those LGBT people to have health disparities. And also the pattern is based on the health outcome. I also look at the moderation and mediation effects on the health outcome depend on the framework that we use. We found that problem-focused coping was a protective factor for depression. And also avoidance coping was a risk factor for depression as well. And once we look at the mediation, we found that loneliness was a prevalence and play a mediating role in association between minority stress and depression. So I can claim that this study gonna be like among the first in Thailand that we start to build up the research, and it's quite like we try to make it as a robust study to be a fundamental for research in the future. And I think for you who may like live in Thailand or other country, especially among Asian country, you may have seen the same situation in your country, that LGBT research is quite limitation. And if you want to start up with the LGBT research, either in like in terms of physical health or mental health, and you don't know how to start up, I think the thing that we did, me and Dr. Matthews and my research team did, is can highlight you how we can start it up. And that is right now we can claim that the LGBT research in Thailand is quite emerging, and we still working on this thing. My research can be a fundamental for other research in the future. And I hope that the strategy that we use can help you to understand what we can create for the next step in your country. So this is what we have in Thailand right now. And I want to return the microphone to Professor Matthews for the summarizing of these topics.
Thank you. That was excellent. Now, when we think about next steps, where do we go from here? In our time left, about 25 minutes, I'd really like for us to have an open conversation about how do we really increase LGBT research and scholar activism in Thailand and in other countries. How do we think about building our research capacity by several different things, right? Developing, translating measures. We have a few that's related to the minority stress, but you might be working with other theories or other areas in which different type of measurements are important. So how do we think about getting developing scales here, or using ones that are established by the World Health Organization, WHO, that can be used translated and used as a starting point here. So let's think about building this capacity. And I just want to remind you of the framework that I described when I was talking about my research. Dr. Perio talked about when he was describing his project. So when we think about starting this program of research, first is understanding the literature. But first, it's identifying a problem, a focal point that you want to start your research on, whether it's, again, a mental health or a physical health issue. All important research starts with a specific problem that you want to either better understand or to reduce. Okay? So some of the things we've been talking about so far, depression, suicidality, anxiety, specific health risk behaviors, or specific health disorders. When we've identified something that we want to work on, the first set of things that we ask ourselves, either from the literature, if it's not available in the literature, then that helps us to guide us with what research we need to start conducting as a fundamental question. So for any health problem, the first thing that we want to know is how often does that problem occur? What are the prevalence rates? Sometimes that information will be in the literature, but oftentimes not as it relates to LGBT research. So now we have some of the first studies emerging that give us rates of suicidality and depression in LGBT adults, right? So we're starting to have that foundational knowledge. So how often does it occur? That's the first question. The second question is, who is likely to experience that problem? Okay. Remember when we talked about the basic demographic factors that might be associated with it, or specific social identities within the LGBT community, because we're not homogeneous. So what are the demographic and identity related variables that are associated with disparities, or who's more likely to have the problem? So in the United States now, we're seeing a lot higher risk among bisexual women compared to trans women and compared to lesbian women. So identifying who within the LGBT communities are more likely to experience the problem. The third is, what are the risk factors? We talked about the Blaznik model that said risk factors include demographic, psychosocial, and unique risk factors. So what can the literature tell us, or what studies, both qualitative and quantitative, need to be conducted about identifying risk factors? When we're thinking about risk factors, we want to look at the literature and the general population related to that problem area to get us at what has been established so far. Then we want to determine, are these some of the same risk factors, or do others emerge? And we start to measure that. And then finally, how do we fix the problem? What interventions either exist or should be developed and systematically tested that help us to understand evidence-based practices for reducing the problem? So I call this the health problem wheel. When we think about any literature, when we're reviewing the literature, we want to understand prevalence, who's impacted, risk factors, and effective interventions. Depending on the health issue, some of this information may be established already in the literature, but a lot of it you may need to start conducting yourself. So here are some of the basic fundamental questions that you could use to guide your program of research. So let's think together about becoming scholar activists, specifically using our research and the information that we developed to help to change the attitudes of society, behaviors of educators and clinicians, as well as to provide support for our communities. So I'm going to stop sharing now. I hope that you will be interested in talking with us about your experiences, as well as I'm happy, either one of us are happy to answer any questions that you might have at this time. So let's open it up for discussion of any questions, or to share any experience with the research that you are conducting. You can also speak, write it in the chat box, speak in English or in Thai. We'll have help with translation. Any questions in chat box? Not yet? Okay. I see someone, yes.
Yeah. My name is Dikki. I'm from, can you hear me?
Yes, I hear you well.
Okay.
Uh-huh.
I study here in Japan. I'm a doctor's student, but I'm studying nursing. And recently, I've been introduced to the LGBT health disparities by the Professor Bayot. He was here. And I also had not the experience, but I had some observations of LGBT in my country, which is with the very minimal, the minority group. And my experience, what I have observed in my country was the research. They do it based on the global issues, health problems of sexually transmitted the diseases, which I thought that may not be my perception was it just give us some the view to the others that this minority group will always have a HIV problem or the sexual transmitted disease, which I feel that may not be all right. I really have a concern for these people that how they feel when somebody, always do the research on the sexually transmitted disease. So when I heard and looked at your presentation on the health problem wheel, that it gives the different perspective than what we are thinking of in my country. So if you have anything that research has been done from those group, that how they feel about those type of the research. So,
Great. Have you experienced in Japan? We have a collaborator who's at the Red Cross nursing facility, Ogato. She is interested in helping to build LGBTQ research in the nursing discipline. She's specifically interested in better understanding attitudes of nursing students about this population, because if lack of awareness of that being a potential minority group in your patient population, negative attitudes have an impact on the quality of care, the quality of the patient-provider relationship, and the importance of needing to know what are some of the unique risk and factors that you, as a clinician, you might need to be taking a consideration with. But I really appreciate your comment about LGBT research is not HIV research.
yeah,
It is
I
not sexually transmitted disease research. That is one area of research, but that does not characterize LGBT research. We are diverse. We have health issues and concerns like other populations, and we have to move away from only funding that as an issue, only teaching that as an issue, and only
yeah.
researching that as an issue. So I really appreciate that comment. Thank you. And I'll put the spelling of Professor Ogato in the chat box. So if you'd like to reach out to her,
Okay,
she's
love
quite
to.
okay.
Thank you so much, and thank you so much for a very insightful presentation.
Thank you as well.
Okay,
All
thank
right.
you.
Who else? How about Seema? Seema, can you tell us a little bit about who you are and your context and what you're interested in terms of LGBT health? No Seema? Okay. How about Jolina? Can you come off and tell us a little bit about yourself and your work that you're doing in this population? Oh, we see someone? All right. All right. You interested? All right. We have a lot of shy people. Or else you're ready for your lunch. Okay. Okay. All right. Well, are there any specific questions then that you might have that I can answer for you before we leave for today? Okay. Mhm. All right, great question. So the question is, um, as we start to build capacity and expertise on health, LGBT health and research around the world, how should we think about the priorities? Um, when thinking about that question, I think priorities will be the same as what will be established from the WHO, as well as country-specific priorities, such as non-communicable diseases, um, aging populations, adolescent mental health. Those are key areas that are priorities for many countries as well as the World Health Organization. And we should build our research in, um, in line with those priorities so that we can start to, because those have been identified as problems within countries and the global community, especially levels of chronic disease, aging population, and adolescent mental health. We want to make sure that we're also focusing in on the problems that are well known and established. But in the meantime, it's clear very strongly from the minority stress theory that's been used in the United States, many places in the West, and now emerging as a theory, a guiding theory in Southeastern Asia, that we know that LGBT populations have unique risk factors. And so being able to determine which of them seem to be the same across countries and which of them may be different. So for example, we're doing Asian regional study that's looking at attitudes towards marriage equality or same-sex marriage partnership policies. And we see that the religious context in some of the countries we're collaborating in are much more powerful than other countries that we're working with. We're seeing that the laws related to same-sex behavior can be quite strict in some countries, which leads to higher rates of concealment, populations being less out, and much more difficulty conducting some certain types of research. So there is the need to consider global initiatives, country-wide initiatives. There is a need to consider the unique factors that may be impacting LGBT populations across countries. And it's important to better understand the context in which you're conducting LGBT research, in which criminalization or religious persecution or religious thought may play a very large role. So those are the level of things that I would consider. Okay, good question. Yeah, have a question. Mm-hmm. Mhm. 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 Okay. All right. So the comment was that in the West, there is a lot of focus on the minority stress theory, but there are other lenses or other theoretical approaches, such as feminist theory, sexual objectification theory, that have implications for informing us about LGBT physical and mental health. And um, the question is, how do we think about other appropriate frameworks that might be important for us to understand research, especially maybe we're focusing on gender specifically and not necessarily sexual orientation, and how more traditional feminist theories might be more applicable. So that's where we're building capacity to have LGBT researchers who are focusing on different topics to translate some of those theories into Thai, start to think about and provide guidance and recommendations about how those theories could be applied to LGBT context in your country, and to start to do research that is relying on those theories. So just like we're looking at minority stress as a theory that can be used across different health disorders, mental and physical. We have some that are specific to our health risk behaviors, such as the health belief model, the precede proceed model. There are many different frameworks that help us to understand behaviors. And so those that are commonly used in your discipline or your area of study should also be used to understand that same concept in LGBT population. So oftentimes, though, those will not capture the unique aspects. So we would use the precede proceed model, right? And also maybe elements of a different LGBT specific framework. But the one framework in LGBT health that's emerging, that's beyond the minority stress model, is this intersectionality framework. Have you heard of this one? Mm-hmm. Intersectionality emerges out of research in the Black feminist theory community that says that the experiences of African American women cannot be understood from a framework of racial oppression alone, and it cannot be understood from a framework of gender and gender oppression alone. That there is something based on the dual position of belonging to two of these categories that creates a whole different set of experiences that can only be understood by conceptualizing those populations from an intersectionality lens. Crenshaw is the original person who established the intersectionality theory, Crenshaw, Kimberly Crenshaw, intersectionality theory. It has been used more recently to understand issues in LGBT population. So that is one of the frameworks that is really emerging. Oh, good question. So one theory, use theories that have helped us capture unique risk factors. Using theories from other frameworks, feminism, gender, that are specific to your research question, right? And using theories that are specific to the health issues, such as self-management, treatment acceptance, et cetera, those theories that help to understand the dynamics around a specific health disorder or health change around a specific disorder. So oftentimes we will work in combination, using a combination of theories. So our work can be influenced by feminist lens, a health behavior change lens, or a minority stress model and the social ecological framework. It's okay to think about how the work that we're doing may need to be influenced by multiple frameworks. Okay. Our friends from Sweden. Yes. Thank you. Can you explain to us the circumstances around LGBT research in your country? You familiar or you know what the landscape is like?